Hello, my name is Joanna Burke and I'm the Principal Investigator for the SHAME project, SHAME standing for Sexual Harms and Medical Encounters. And we're really thrilled that everyone can come to this academic symposium, which is looking specifically at medical and psychiatric aspects of sexual violence. So welcome. I have some housekeeping that I need to do. So basically, your cameras and mics for the guests should already have been turned off, but if they haven't been, please do it now. That shouldn't be necessary. This event will be recorded, but only the speakers will be filmed. So you don't have to worry if you're a guest for the symposium, you won't be filmed. And you can, of course, come back and listen to the discussion at your leisure on another occasion. On the side, there's a chat function. And so please, put your comments, put questions, whatever you want in that chat. Now, there will not be a formal Q&A, but we will get back to you about those things that you post in the chat when we go offline. This event, obviously, you're here, you know that it's dealing with sexual violence, and this can be really difficult. It can cause distress or simply feeling of unease. Please feel free to go out and come back in if you want it at a later stage. Everyone who signed up has been sent a safeguarding link, but safeguarding statement. But if you've lost it or can't find it, that is also in the chat. So please have a look at that if you need to, if you want to. And for those of you on Twitter, please feel free to tag us in any comments at SHAME without an A, so SHME _ then BBK. So that's at SHAME without an A _ BBK. I think that's all the housekeeping that needs to be done. So again, welcome, really pleased once again that everyone could come to this event. Just to say that SHAME is a Wellcome Trust funded research project. It's an interdisciplinary research project, and we've been going nearly 3 years at this stage. And some of the members of the SHAME project are here with us today. I want now just to introduce ourselves, just so that everyone can put a face to the videos. Some of you may have, it's not necessary, but some of you may have listened to the papers, which are all on our website, because we're not actually going to be giving formal papers. We're going to really be we've got 2 discussants, and then we're going to discuss the whole thing as a group. But even if you haven't listened to the videos, you can do that at a later stage. And actually, you may find that these introductions will indicate to you which videos you're most interested in watching after this event. But so first, let's just do introductions. I'll start with myself, and then we'll just go in alphabetical order. My name is Joanna Burke. As I said, I'm a Principal Investigator of the SHAME project, and I work on global history of sexual violence, and I'm based at Birkbeck University of London. Ruth Beecher.
Good morning, everyone. It's great to be here for the second session. My name is Ruth Beecher. I'm a historian. I also work on the SHAME project with Joanna at Birkbeck in London. And my research is a recent history of the ways nurses, GPs, doctors, clinical psychologists, psychiatrists identify and respond to child sexual abuse in the community. So it's really all about early identification and responses. And the paper that I recorded was about what we now call harmful sexual behavior, but in its infancy was called, I guess, young abusers or young sex offenders, and trying to trace the history of that since the 1970s. Really looking forward to today. Thank you for inviting me.
Angelica Clayton.
Hello, everyone. My name is Angelica Clayton. I'm a PhD candidate in the History of Science and Medicine department at Yale University. My talk for this symposium was titled Traumatic Entanglements, Rape Trauma Syndrome, and the Interrelation of Mind, Body, and Environment, which was taken from my dissertation. And it tracks the history of rape trauma syndrome, which was a little well-known diagnosis, well, at this point, that was used more widely from the 1970s to the 1990s in the United States, and how rape trauma syndrome sort of made claims about the embodied, social, and environmentally embedded nature of psychological trauma as it moved from clinical research into courtrooms. So excited to be here for the second session and excited for our discussion. Thank you.
Lovely. Kate Davison.
Hi, everyone. My name is Kate Davison. It's great to be here. And I said thank you yesterday, but I'll say it again today to the organisers and to Joanna for hosting this event. I finished my PhD in 2020, so just a little while ago, at the University of Melbourne, where I am currently a postdoctoral career development fellow, honorary. But I'm joining you today from Berlin, which is where I currently live and work at the Centre for the History of Emotions at the Max Planck Institute. And from September, I will be the German Academic Exchange Service lecturer in queer history at Goldsmiths University of London. My paper that I've submitted to this conference is called Paraphilia or Harmful Sexuality, explaining the absence of victims in early clinical research on rape and pedophilia. And this arose out of my dissertation project, which was a transnational history of homosexual aversion therapy. And what I looked at in my dissertation was the rise and spread and uptake of Pavlovian the Pavlovian behaviorist paradigm in the treatment of sexual so-called disorders. And so what I presented here arose out of some of that research.
Thanks. Susan Egan. Suzanne, sorry, Egan.
Sorry. Hi, my name is Suzanne Egan. I'm from the University of Sydney in Australia. The title of my paper is The Utility of Trauma as a Feminist Practice. And basically what I was interested in that paper is looking at the ways that trauma, in particular neuroscience of trauma, is being taken up as a feminist practice, specifically looking at Australian sexual assault services, and that now sits within a larger project that's looking at the rise of trauma-informed care across domestic violence, sexual assault, and broader social welfare services.
Thanks. Gabriel Everall.
Hi, my name is Gabriel Everall. I'm a poet. I have a PhD and I'm currently studying at Melbourne University in postgraduate studies. The title of my paper is Clitoridectomies and Aversion Therapy, Who Says Psychiatry Hasn't Been Sexually Violent Toward Women?
Thanks. Lisa Featherstone.
Hi, I'm Lisa. I'm here at the University of Queensland and I'm a historian. My work's mainly been around the kind of intersections between medicine and the law around sexual violence in the last 5 years, I guess. And yeah, I'm looking at compensating trauma at the moment. But
Great, thank you. Patsy Frawley.
Hi everyone, I'm Patsy Frawley. I'm currently speaking to you from New Zealand. I was recently from Australia, just started a position at the University of Waikato as the Associate Professor in Disability and Inclusion Studies. Myself and my colleague Amy O'Shea, who's from Deakin University, which is where I previously was, we presented a paper here around preventing violence against women with disabilities, and embedded within that paper is a lot of our practice that we have set up in both our methodologies of doing research with women with disabilities around violence and abuse, and particularly using a sort of respect for relationships framework, using narrative approaches to research. And some of the work that we've done also we shared in the paper around looking at how access is understood and can be I guess, supported in domestic family violence and sexual violence services in Australia. Some of that research was funded by the Australian National Research Organisation on Women's Safety. So yeah, thank you very much. And I'm sorry, Amy can't be with us tonight. And thanks very much to the organisers, Joanna. Thanks very much for having us.
Samina Mullah.
Good morning, and nice to be here with everyone again. I'm speaking to you from Milwaukee in the US, and it's 3 in.the morning. So if it's a little rough, that's why. I'm an anthropologist currently at Marquette University, but as of the fall, you can find me in Women, Gender, and Sexuality Studies at Emory University in Atlanta, Georgia. My paper was Nursing from the Stand, Victimized and Victimizing Bodies, and it's based on a chapter of a forthcoming book that examines the role of forensic science and expertise in kind of evolving narratives of racialization in the courts in the United States.
Thanks. Gethin Rees, I think you're next.
Good morning, good afternoon, good evening to everybody. My name's Gethin Rees, and I'm a sociologist at Newcastle University, the one in the UK, not the one in Australia. So my work has been looking at the intersection of medicine and criminal justice, predominantly looking at the area of the forensic response to sexual violence. The paper that I've been given as part of this symposium has looked at recent work that I've been doing on the sleepwalking defense, and in particular the alcohol-induced sleepwalking controversy, whether alcohol can trigger sleepwalking behaviors, which can result in criminal actions. The debate particularly focuses around a particular expert and their what I argue is their marginalization within the sleep medicine debates and how that impacted a particular sexual offence trial. Thanks very much.
Thanks. Elizabeth Roberts-Pedersen.
Hi everyone, I'm Elizabeth Roberts-Pedersen. I'm a historian at the University of Newcastle, the Australian version. And the paper I gave was on researching sexual violence in Australian military history.
Thanks. Evan Cedric-Stell.
Great. Hi, everyone. And I'm really happy to be here this morning as I wasn't able to make yesterday's session. My name's Evan Cedric-Stell. I'm a PhD candidate at Birkbeck University of London. But like Kate, coming to you from Berlin today, my PhD research focuses on political and social meanings of popular understandings of mental ill health, specifically depression, as it's sort of talked about. But my paper was called Sexualized Violence Prevention in Organizational Contexts, and is sort of based on research that I did during my qualification and work as a social worker. And it looks specifically at community-based approaches to sexualized violence and the impact on communities dealing with sexual violence through the framework of vicarious trauma.
Thanks. Louise Stone.
Hi everybody, my name's Louise. I'm from ANU, which is the Australian National University in Canberra in Australia. And for the last 6 years, I've been working on qualitative research around junior doctors who've been sexually assaulted by senior doctors within the system. So my paper is about called Achieving Zero Tolerance, which of course is impossible, but that's the name of the paper. I'm also heading up an international book on this subject, so I'm learning a lot of geography and also finding that this behaviour, unfortunately, is fairly universal, although its expression changes whether you're in Nigeria, Japan or Mexico. So I look forward to meeting everyone. Sorry I wasn't able to be here yesterday, but I'm looking forward to the conversation tonight, and thank you for everyone for inviting me.
And last but not least, Stephanie Wright.
Everyone, so I'm a historian of modern Spain. I'm also a researcher on the Shame Project with Joanna and Ruth. My research looks at sexual violence under the Francoist regime in Spain, and looking at the work of forensic doctors and psychiatrists within court cases relating to sexual violence.
Lovely, thanks. So I'm sure everyone sees we've got a really rich group of researchers and activists here. The way we're going to run the rest of the session is there's going to be 2 discussants. I'll start and then I'll hand over for 20 minutes, and then I'll hand over to Stephanie Wright. And then we will go in, we'll go into a discussion type period. But what I want to start with, a poem that really had a big influence on me many years ago when I first read it, and it got me really interested in working on sexual violence. And it's from Adrienne Rich's book, Diving into the Wreck. And it's her poem, which is simply called Rape. And it goes like this. There is a cop who is both prowler and father. He comes from your block, grew up with your brothers, has certain ideals. His ideals stand in the air, a frozen cloud from between his unsmiling lips. And so, when the time comes, you have to turn to him. The maniac sperm still greasing your thighs, your mind whirling like crazy. You have to confess to him you are guilty of the crime of having been forced. And you see his blue eyes grow narrow and glisten. His hand types out the details and he wants them all, but the hysteria in your voice pleases him best. You hardly know him, but now he thinks he knows you. He has taken down your worst moment on a machine and filed it in a file. He knows, or thinks he knows, how much you imagined. He knows, or thinks he knows, what you secretly wanted. I think Rich's poem alludes to many of the topics that emerge in the talks that form part of this symposium today. And these include the difficulties in speaking about rape, including fears of not being believed, or worse, being judged blameworthy, as well as the kind of miasma of shame, thickly clinging to that word, victim. Her poem also alludes to bodily disgust, traumatic aftermaths, and the role of language, including poetry, to communicate pain, loss, resentment, fury. The poem draws attention to the stigma attached to being a survivor of sexual abuse and having to confess to being guilty of the crime of having been forced. Sexual harms, in other words, destroying worlds of sociability. But I think the reason I really like this poem is it does much more than simply recount a response to rape. It places the reader as the violated other, the you in the poem. You see his blue eyes, the hysteria in your voice pleases him best. So on the one hand, we have the suffocating proximity of people who engage in harmful sexual acts. And on the other, the distance, detachment of those who are supposed to provide help. This learned detachment has been a theme of a number of papers in this symposium, which focus on bearing witness to the distressed person. And on some occasions, we're talking really about literal witnesses, such as the nurses that Samina Mullah so powerfully evokes. The clinical, ideological, and emotional labor provided by sexual assault nurse examiners within the courtroom requires them to push back against puritanical awkwardnesses, against false systems of belief, those ideals or rape myths that Rich writes so powerfully about, that kind of stand in the air, a frozen cloud from between unsmiling lips, and against assumptions about what is normal. Muller's discussion of about the normal, which other people, of course, in the symposium also return to time and again, is particularly pertinent for forensic nurses who, perhaps unlike police, jurors, and judges, are forced often to acknowledge the fluidity of normal in terms of bodily traces required, of course, for corroboration, emotional comportment, for example, defiant recitations of facts rather than tears, and self-preservation routines, including delaying disclosure. these are also topics that Angelica Clayton addresses, but from a historical perspective, by turning to the diagnostic category that was invented in the early 1970s by psychiatric nurse Anne Burgess and sociologist Linda Holmstrom, which was rape trauma syndrome, RTS, rape trauma syndrome. Now, RTS has today been superseded by PTSD, but it was incredibly powerful in the 1970s and 1980s. And I think in part this was because it located rape as a gendered diagnostic syndrome that inflicted specific harms on girls and women. In other words, it was rape trauma syndrome, not PTSD. A general category due to trauma due to combat or car accidents. Now, similar to Muller's nurses, forensic nurses, RTS was fundamentally about what was normal. Burgess and Holmstrom observed that women responded to rape in a wide variety of ways, none of which should be used to deny the reality of their assaults. They sought to remove narratives imposed by law enforcement or psychiatric experts who, again, in the words of Rich's poem, know or think they know how much you imagined. Instead, RTS insisted on paying attention to the speech acts and comportment of victims. Burgess and Holmstrom were, of course, not the first people to make this argument. 4 years before their landmark article and book, Sandra Sutherland and Donald Sherrill published Patterns of Response among victims of rape in the American Journal of Orthopsychiatry. This was the first major attempt to delineate the normal and predictable psychological after effects of rape. But I think the reason that Burgess and Holmstrom really has made a mark in this field is because they took this a lot further. They provided so much more evidence. They popularized it subsequently, not only in numerous medical journals, but also amongst survivor communities. And they bravely insisted that even laughing might be an appropriate coping device for some victims. Now, this is a topic that I have a particular interest in, but I think Clayton's argument identifies an important shift from what was originally conceived of as emphasizing women's embodied responses to what courtrooms translated into performances. And of course, not only was this a highly raced performance, but it was also influenced powerfully by other intersectionalities such as sexuality, gender, including the performance of male victims, which is fought for some very unique reasons, age and generation, religion, and constructed notions of able-bodiedness. And I think this latter issue is discussed really eloquently by Patsy Frawley and Amy O'Shea in what is, I think, can only be described as a devastating critique of the multiple ways victim survivors who happen to have disabilities are rendered invisible. The problems that they identify have a very long history, unfortunately. And I think a crucial aspect of the neglect is the way people with disabilities are thought to have a diminished sense of personhood. People with physical or learning difficulties are not rights holders. Rather than being acknowledged to be agents in their own lives, they are passive objects of care. And many forms of care are themselves harmful. Many are told that the abuse makes them special. They are not given sex education, so in fact may not even be aware that they are being molested. Many are conditioned to be over-compliant and are dependent on offenders for their day-to-day care. We all know, everyone here in this room knows that justice systems are notoriously unsympathetic to people of all types who have been sexually assaulted. But physically and intellectually impaired victims are some of the most powerless complainants, particularly if minoritized in other ways as well, being Black, for example. Indeed, I think, at least for me, and I think for most of you as well, the most distressing aspect of many of the papers in this symposium is the extent to which victims are blamed for their own violation. Again, in Rich's words, victim survivors are required to confess to him, "You are guilty of the crime of having been forced." Elizabeth Robert Peterson's paper, I think, shows this in really, really stark ways when members of the Australian Armed Forces during the World Wars claimed that even very young victims were, in fact, prostitutes and therefore, of course, fair game. And when these victims are racialized, the perpetrators dealt with extraordinary leniency. Fundamental issues of formal justice intrude in many of the papers. I think for me, some of the most interesting are those that draw attention to the construction of expert knowledge. This is explored most directly by Gethin Rees when he turns to get this right, alcohol-induced sleepwalking defense. That is the defense that a man is not responsible for his actions because he had been sleepwalking as a result of excessive alcohol abuse. Rees's close reading is an exemplary example of science and technology studies with its emphasis on the social construction of, or socially constructed nature of scientific knowledge and its exploration of how knowledge is created, contested, recreated, recontested. And listening to Rees's really amazing paper, it made me curious about, of course, there's another side to these debates, those affecting not offenders, which is what Rees focuses on, but victims. In the late 19th and early 20th century, for example, there were also these furious scientific debates about whether chemical technologies, here they're referring to alcohol, chloroform, nitrous oxide gas, whether these rendered female complainants responsible for their own sexual assault. From the mid-19th century onwards, such questions appeared time and again before the courts, even implicating William Wilde, the father of Oscar Wilde, in a major court case, 1864. Where he was accused of using chloroform to sexually assault his mistress. Remember, this was a time when chloroform was as easily to purchase in shops and from street hawkers as was alcohol. So the questions they asked were, these experts asked were, well, could stupefying substances, as well as hypnosis, and this was a parallel debate at the time, could stupefying substances bypass free will? What is free will from a science point of view, and what can bypass it? Did a girl or woman who succumbed to a man's embrace while under the influence prove that her true self not only consented, but was actually sexually voracious? And crucially, who or which experts were to be believed? Rees's arguments about offenders in the late 19th century, I think, his work on offenders in the late 20th century, I think provides a really interesting lens with which to explore these historical questions as well. Now, it's not surprising, given that this symposium really does focus on medical and psychiatric aspects of sexual violence, that attention is paid to the medicalisation of rape and rapists. One approach here has been to focus on sexual abuse by doctors of doctors, most notably in Louise Stones's paper, which foregrounds relations of power. and in Gabriel Everald's study of the role of medical professionals in carrying out clitorectomies. The resulting trauma is due not only to the assaults themselves, but also to the responses to the abuse by others. This stream of research takes trauma as its starting point. And I think it's fair to say that since the 1980s, at least, trauma has become a master concept in the field. A number of really excellent papers in this symposium have touched on trauma in the context of victim survivors. This includes a really interesting defense of neuroscientific approaches to post-assault trauma by Suzanne Egan. Egan goes as far as to argue that neuroscience does not have to be pathologizing for survivors, but actually can be part of empowering feminist practices. Other researchers focusing on medicalisation turn towards men who inflict harms. They ask, well, are rapists actually mentally ill? This question has been debated by psychiatrists, psychologists, forensic nurses, and other medical professionals since the late 19th century. And the most influential commentator was probably forensic psychiatrist Richard von Krafft-Ebing in his 1886 classic, Psychopathia Sexualis. In more recent debates, when I say more recent, since 1952, I think this shows that I'm an historian, more recent decades since 1952, the mental instability of sexual offenders has been debated in the various editions of the DSM, the Diagnostic and Statistical Manual, called the Bible of American Psychiatry, and the International Classification of Disease, the ICD, which is used even today by 140 member countries of the World Health Organization. In this symposium, however, Kate Davison looks at a number of Australian and American psychiatrists and their role in labeling perpetrators of sexual harms as men suffering from paraphilias. So para coming from meaning deviation, philia meaning attraction. So paraphilia, attraction to deviation. She shows that first, that women victims were really basically ignored by forensic psychiatry, at least prior to second wave feminism. This is not a European discourse. This is a British and American Australian discourse. There's a different story to be told about the Europeans. And second, that the role of psychiatrists has been on normative versus non-normative sexual behaviors rather than harmful versus non-harmful ones. And by this, she means they're concerned with what is normal rather than what is harmful. In other words, they're really interested in homosexuality rather than harm to young victims subjected to sexual practices. My own research looks at the opposite of Davison's story. And that is, I think it's really interesting not only to look at medicalisation, but also when is medicalisation rejected by psychiatrists? As happened during the debates by the various authors of the DSM about paraphilic coercive disorder, PCD, paraphilic coercive disorder, and hebephilia. That's the sexual preference for children aged between 11 and 14. Both of these proposed diagnostic terms were rejected by the psychiatric community. And I think their fate can tell us a great deal about, again, what is conceived of as normal. The authors of the DSM argued that both PCD and hebephilia should not be listed as paraphilias because male sexual aggression was normal, as was being sexually attracted to pubescent children. They also drew on ideas of what causes harm and what constitutes consent when it comes to young people under the legally defined age of consent. This is an issue which Ruth Beecher addresses in her particularly thoughtful paper on children who sexually offend. Why shouldn't they be treated as mini sexual offenders? Are there cycles of abuse with child victims becoming adult offenders and child offenders becoming adult offenders? And I think she has really important things to say in her paper about the transfer of knowledge between US and UK psychiatrists and the role played by lucrative medical and psychiatric marketplaces. But finally, what can be done about high levels of sexual abuse? A couple of really excellent papers look at the use of aversion therapies, often verging on torture, to dissuade men from continuing their offending. They ask, well, why, when and why did this become an unacceptable practice? Other studies focus on courtrooms and sentencing practices, occasionally edging close to a carceral feminism that would see offenders locked up for very long periods. Ironically, a practice that probably increases levels of sexual violence, if largely against boys and men in the prison system. This is why Evans Sedgwick Gell's paper, I think, is particularly interesting. Because what he does in his paper is he points to the need to turn away from an exclusive focus on carceral politics towards community ways of dealing with sexual violence, both for survivors and for those who have committed harms. So just in conclusion, I have some concerns about the papers. I think my chief one is the relentless negativity. For all the talk of survivor-focused interventions, there is actually very little about empowerment and flourishing. With a few notable exceptions, there is also very little sense of history. Now, before I hear a chorus of, that's not my discipline, I was given limited time to speak, and of course, Joanna, as an historian, you would say that. Let me briefly say why I think history is actually important. It seems to me that snapshot approaches can limit possibilities for effective activism. I think it's really helpful for us to think about deeply embedded, and here I'm talking about centuries-long embeddedness of rape myths, court injustices, medicalized exploitation. I think it's useful for our theorizing to reflect on the fact that the concept of intersectionality appeared in the context of debates in the 1970s and 1980s, as, by the way, was talk about decolonizing the curriculum. It is relevant that it was more than 3 decades ago that disabled activists adopted the slogan, nothing about us without us. The papers by Ruth Beecher and Lisa Featherstone, her paper on compensating rape victims for their suffering, I think are particularly strong in providing really clear arguments for why looking at changes in practices and ideologies reveal underlying structural shifts, which a single-time snapshot may fail to identify. Such research cuts through universalist, single explanative models, which are often dependent, not always, dependent upon assumptions based on autonomous, self-sufficient individuals. And they also point to the importance of context and the specificities of environments, embodiments, and emotions, as do all of the really great papers in this symposium. This is, I think, the reason, though, why I enjoyed in particular the paper by Jacqueline Taylor, which focuses on boys and young men who are sexually exploited in trafficking in Jamaica. Critical race theory, in other words, racialized frames as well as gendered ones, are particularly helpful, as is her focus on the economic realities for men who sell their bodies to white tourists. She makes a powerful case for rejecting binaries, such as home equals safety, while street or beach equals exploitation. Her paper inhabits the messy worlds of ambiguity, constrained agency, and struggle. And this really is my final comment, I was left wondering what theoretical models we have for thinking about change, and dare I say it, improvements. A number of the papers pointed to the importance, indisputable in my view, the importance of 1980s feminism. But I was still left without a sense of, well, why the 1980s? After all, 19th century feminists were also deeply involved in anti-rape activism, especially in age of consent debates, in anti-slavery movements, and what was called at the time white slavery, which was fundamentally about the sexual abuse of white children. Feminists and our allies, I think, need a better sense of how change for the best happens by exploring progressive movements, even those which were fleeting, perhaps inadequate, of course, always. I think we can imagine anew ways to forge rape-free worlds. Those are my comments. Let me now hand over to Dr. Stephanie Wright. Thank you.
Thanks very much, Joanna. A lot to think about there, and I think some of the points that I'm going to make touch upon some of the points you made there. Just before I start, I wanted to say thank you to all the speakers for all your very incredibly rich and fascinating papers. It's been a pleasure to watch them, but also a real challenge to select a collection of things that were out of those papers. So the theme of the conference is sexual violence, medicine and psychiatry has been broached from a number of different perspectives, both contextual and disciplinary. So I'm going to try and make sense of those under three broad headings. So the first, the role of medicine and psychiatry in court cases linked to sexual offences. Secondly, medical and psychiatric approaches to the victims of sexual violence. And then thirdly, the medical and psychiatric approaches to the perpetrators of sexual violence. So all of those categories are kind of relevant to each other. So there will be some mishmashing of each of those within that, but that's the kind of broad structure that I'll try and stick to. Okay, so firstly, so several of you offered insightful papers on the role of doctors and psychiatrists within the courtroom, with most of you in some way or another pointing to the paradox of medical evidence, which is at once perceived as an objective arbiter of truth, especially by juries who have come to expect to see medical forensic evidence at trial. But you've also pointed out the highly ambiguous nature of this evidence, which is incredibly permeable to highly subjective cultural understandings of sexual violence, or even permeable to factors which have little to do with the case in hand. So the keynotes from Samina Muller and Gethin Rees were particularly instructive in this regard. So Samina, in your paper, this permeability was particularly clear through your analysis of how sane nurses reproduce cultural notions of the feminized body. And I was particularly struck by the scrunchie analogy that was used by one nurse, which was a clear example of the very ambiguous role of nurse witnesses in the courtroom. So nurses might try to bolster the victim's case by countering jury preconceptions over the bodily manifestations of violence. In other words, by reassuring the jury that a lack of bruising or tearing is perfectly normal, while at the same time playing into pre-existing notions of femininity by reframing anatomical resilience as something inherently feminine. This idea that forensic medicine in a courtroom can reinforce broader, more cultural understandings of gender reminded me of Gethin's 2012 work with Yvonne Crozier on forensic medicine in the Victorian period, and your conclusion that forensic specialists didn't challenge but rather reinforce gendered understandings of sexuality, and particularly with regards to female passivity. And in this sense, we can consider forensic medicine as something of a mirror which reflects and reproduces social inequalities. But if we are to situate forensic medicine within its social context, we also have to situate it within its professional context. And again, this is something that comes out in both Samina and Geth's keynotes. So sane nurses not only testify to the victim's credibility, but also to their own credibility. And there can be a degree of slippage there between the nurse as an objective expert witness and the nurse as a witness to more subjective issues such as pain. As Gethin's keynote also very clearly showed, this duality of the expert as both a professional and a person with their own agenda, including career ambitions, can also have a profound impact on the use of forensic evidence at trial. The case of Colin Shapiro and his professional motives for taking a particular stance over the question of whether alcohol is a trigger for sleep parasomnias is a striking example of how factors that have nothing to do with the specific sexual assault case under examination can enter the courtroom through the medical professional. In both of your papers, you point to the unreliability of medical evidence in the courtroom. And Samina, in your keynote, you mentioned how sane nurses admitted that genital injury means nothing, which echoes critiques of forensic evidence voiced by Rose Corrigan, amongst others. So perhaps a talking point for the discussion afterwards could be, what does medical and psychiatric evidence really bring to the courtroom? Should we get rid of it altogether, given how easily it can be misunderstood by juries and or dismantled by the defence? Or is it a case of incorporating greater acknowledgement of the ambiguities of medical evidence into court practice, especially with regards to the training of jurors, and pivoting to different kinds of medical testimony, such as sane nurses being able to act as witnesses to victim trauma? Here I'd like to refer to Suzanne Egan's contribution to the conference, which seemed to offer a more optimistic view of the role of medicine and body knowledge, as you refer to it, in supporting victims through trial. Though feminist discourses have been sceptical about the work of psychiatrists relating to the victims of rape, which have often been seen to pathologise female victim survivors and detract from the social and political roots of sexual violence, Suzanne posits that neurobiological insights can help to explain the embodied effects of sexual violence and can help to explain, for example, why some victims may have only fragmented recollections of an assault. And in this sense, discussions of trauma can be enabling for victims on a number of levels. Perhaps within this discussion of or a kind of reassessment of the utilities of trauma, it's helpful to reflect upon Angelica Clayton's historical discussion of rape trauma syndrome, or RTS. There are some really interesting and indeed, I think, quite appealing aspects of the RTS diagnosis as conceived by Anne Burgess and Linda Holmstrom in the 1970s, notably the ways in which RTS differed from PTSD in that it acknowledged the role of social environment in contributing to a rape victim's trauma. And through this situated approach to trauma, Burgess and Holmstrom were able to account for how disbelief encountered by the victim in the aftermath of an assault might exacerbate the long-term psychological impact of rape for victims. There's a lot to be admired in this approach, though like many second wave feminist responses to rape dating from this period, Susan Brown-Miller being the most prominent example of that, RTS as a diagnosis helped to foster a particular vision of sexual violence, which was blind to issues of race, notably, and helped to create a prototype victim, which was created in the image of the white woman nurtured by prevailing racial stereotypes of Black bodies as resilient to abuse. And so any reevaluation of rape-related trauma must be sensitive to cultural and historically constructed understandings of trauma over time and the potential for these to reproduce socially constructed prejudices within the courtroom. Okay, so now just to move on to reflect on how medicine and psychiatry can help us to think about the victims of sexual violence. So as Lisa Featherstone highlighted in her paper, the willingness of the courts to recognise or see victim trauma is relatively recent, and until the 1970s and 80s, compensation for victims tended to be calculated according to practical losses and physical injury. The idea of what the courts are willing or able to see is interesting, and a few speakers also made some insightful contributions to who are visible in society as victims of sexual violence. The third keynote address from Patsy Frawley and Amy O'Shea in particular outlined the invisibility of disabled victims of sexual violence, especially those with intellectual disabilities or those with disabilities resulting from brain injury, despite a general acknowledgement that both men and women in this position are more likely to be victimized in their compared to their non-disabled peers. So even though we know this is the case, society is still largely unable to see these victims. Patsy and Amy drew on Tom Shakespeare's interactional model of disability and the WHO's ecological model of disability to explain the two-way relationship between an individual and their environment, to highlight the barriers to support faced by those with intellectual disabilities or brain injuries who've experienced sexual violence. I'd like to pull out two of these barriers, because they could perhaps be applied more broadly and might be interesting to discuss in the Q&A. So firstly, community level factors, where people with learning disabilities are often perceived as unproductive or even non-citizens, and can therefore be invisible to abuse services that only, for example, send surveys to people within private homes. Similarly, at the social level, policies and practices such as the segregation of disabled people in separate schools and other institutions further others disabled people, making them invisible to sexual violence services. And this attention to how social structures render certain victims invisible resonated with a few other papers. And here I'm not only thinking about Angelica's discussion of RTS as a white diagnosis, but also Ruth Beecher's discussion of how notions of class prevented certain researchers into child sexual abuse from seeing incest between siblings as sexual abuse. In the first part of this talk, I focused on the courtroom, but we also must forget that in order to get to trial, sexual violence has to be detected and or disclosed. And there are many barriers to children disclosing sexual violence. And Ruth's work in this paper and more broadly emphasised the onus placed on medical practitioners in the community to see sexual abuse. As I think you mentioned, Ruth, such abuse can hide in plain sight if class-based assumptions of normative child sexuality are allowed to shape medical professionals' understanding of sexual violence. On this note, it's perhaps worth thinking about how different constellations of sexual violence are more visible or more readily acceptable than others. I saw in the chat somebody mentioned that male victims are often left out of these conversations because that perhaps stands outside of people's assumptions about sexual violence and what the perpetrators and the victims look like. In your paper, Ruth, you cite Nicholas Groff's assertion that 82% of sex offenders have been victims themselves, many of whom become offenders upon adolescence. The perpetrator as former victim is also something often left out of academic and public health discussions of sexual violence, perhaps precisely because it disrupts the comfortable victim-perpetrator binary and forces us to acknowledge societal failures to support young victims and potential victims of abuse. So for some, it's perhaps easier to double down on retributive approaches to justice than to adopt more empathetic approaches to prevention, if the latter means acknowledging a degree of collective responsibility for crimes that many find too heinous to contemplate. And in that sense, Evan's paper relating to kind of community responses to sexual violence was really interesting, and I look forward to hearing more about that in the Q&A. In Jacqueline Sanchez-Taylor's paper on trafficking discourses in Jamaica, she also offers a detailed exploration of how a particular framing of sexual violence can obfuscate and even exacerbate the causes of sexual violence. As you highlight, in Jamaica, the entrenchment of this trafficking discourse has created the impression that children are taken against their will from safe homes, ignoring the role of poverty and abuse, particularly against the LGBTQ+ community, in pushing people out of their homes, and ignores the possibility that sex work can be a choice and can offer an escape from an abusive home. As you highlight, the trafficking discourse also precludes an evaluation of the supply side of sex work, especially the rather ambiguous role of white female tourists in feeding these industries. And then if we return more closely to the medicine psychiatry focus of the conference, there's also a link here with Louise Stone's paper on the sexual abuse of doctors by doctors. The doctor, who is often perceived in our society as a healer, is often above suspicion and it can be extremely challenging for those abused by doctors to challenge such decisions, particularly in the case of renowned experts who are perceived to be carrying out important work into human health and disease that might benefit society as a whole. I'm not sure how many of those who are joining the discussion from outside of the UK will have heard of this case, but in the 90s there was a very infamous case of a GP doctor called Harold Shipman, who murdered hundreds of patients in his local community. And the way that he managed to get away with that for so long was because he was a trusted member of the community, and also because his victims were mainly elderly women who are a particularly invisible demographic within our society. So even though Shipman's crimes weren't sexual in nature, there are echoes between this case and Louise's work, where female doctors are victimized by their male colleagues and are kind of similarly disempowered, but often for different reasons, including the pressures of professionalism, for which women, or for women often means absorbing with grace and decorum the deeply unprofessional behaviour of their male co-workers. Gabrielle Everall's paper also spoke to the theme of the medical professional as perpetrator. So in the cases that you outline of the use of clitoridectomy in aversion therapy, the doctor's position of power enables them to mask violence as cure. And I think this particular paper raised some really interesting questions over the very meaning of sexual violence. The mutilation you described was clearly violence, and that it was non-consensual maiming, and there's clearly a sexual element there, in that the body parts being maimed were constituted the patient's genitalia in a bid to alter their sexual orientation. But this seems kind of somewhat different to rape, and I'm not quite sure what to make of that. But I'd be really interested to hear your thoughts on what makes violence sexual. Is it to do with an imbalance of power? Is it to do with body parts? I know Joanna has written about this before, and I wondered if your thinking had evolved on this point since you wrote your first book on rape, which didn't have as much of a medical focus as your current research. Another question we might want to reflect on in the Q&A is the extent to which the recent high-profile outing of sexual perpetrators in the medical profession has facilitated a greater reckoning with other medical perpetrators of sexual violence. I mean, here I'm thinking especially about Larry Nassar, the former doctor of the USA national gymnastics team, who was found guilty of abusing hundreds of young women and girls, and which was the subject of a very popular 2020 Netflix documentary called Athlete A. So do these kind of high profile cases empower victims to come forwards, or are they easily dismissed as isolated abominations? In the Nassar case, there seemed to be a particular shock because of the vulnerability of his young victims, who in their star-spangled banner leotards almost seem to embody American notions of girlhood innocence. In her book Speaking Out, the academic Tanya Cerizia argues that despite the potential for justice, which is seen to offered by the concept of breaking the silence, these practices are often ambivalent in that they continue to prioritise certain voices, namely white, middle class, respectable voices, while marginalising others, namely people of colour, those deemed unworthy due to their reputations, etc. Indeed, Elizabeth Roberts-Peterson's paper speaks to the persistence of victim-blaming discourses by high-profile politicians and military personnel, despite Me Too, which brings into question the longevity of the 2017 onwards Me Too movement, especially now that big fish of Weinstein, Epstein, and Maxwell have been dealt with or are being dealt with. And as Evan Sedgwill-Gell mentions in his paper, despite the fact that sexual violence is often an intimate act, disclosing its sexual abuse is often viewed as an inherently political one, and can lead to backlash against the victim, which is deeply traumatizing in itself. And then just finally, I wanted to end with a few reflections on perpetrators. So as a few of you highlight, the victimizing body is rarely acknowledged in court cases relating to sexual violence. That's not to say that medical and psychiatric experts have been uninterested in the figure of the perpetrator. And Kate Davison's paper on the researchers Kurt Freund and Neil McConaughey offers a fascinating insight into shifting medical conceptualizations of the sexual perpetrator over time. In the 1950s and 60s, sexual crimes such as rape and paedophilia were gathered under the broader heading of paraphilia alongside non-harmful behaviours like homosexuality. In this sense, the work of Freund and McConaughey reflected shifting understandings of sexuality, initially understood through the lens of normativity, which, as I read it, seemed to include greater emphasis on behaviours perceived to pose a moral risk to society. And later, there was a shift towards viewing these paraphilias through the lens of harm. Here we might want to take another discussion point, and I'd be interested to hear the panel's or the speakers' reflections on the cultural influences which have shaped medical understandings of the perpetrator. So in your paper, Kate, you point to the rise of feminist discourses in forcing distinctions to be made between harmful and non-harmful paraphilias. Guess you identify less tangible conceptions of normal behaviour of perpetrators, which slip into Shapira's supposedly objective expert testimony. Ruth, in your paper, you discussed the influence of US medical culture geared towards the greater marketization of care and how this threatened to foster a greater propensity to define young people in the UK as sex offenders. So how have different medical and legal cultures defined perpetrators differently, particularly in the Global South, which is relatively underrepresented at this conference? Lisa, I found your paper really interesting in this regard, as your analysis of compensation cases identifies a greater willingness to acknowledge or see a perpetrator's crimes when these are assessed through the lens of a victim's trauma. It seems to be, and I'd be interested to hear your reflections on this, that part of the issue is that the courts are far more willing to compensate the victim when this has no bearing on punishment of the perpetrator, which begs the question, why are the mainstream courts so willing to prioritise perpetrator well-being over victim trauma, particularly in a system which is mainly punitive and doesn't have these other kind of restorative or transformative justice approaches. And then thinking more intersectionally, I had a final question for Patsy about whether you'd worked with intellectually disabled perpetrators of sexual violence. A lot of the issues you discussed, such as social isolation, high risk of abuse, and the general refusal to acknowledge the sexual citizenship of young people with learning disabilities often means that they are left out of conversations about sex and sex education, which can make them less likely to understand consent, which is already a deeply complex issue, and more likely to commit acts of sexual harm. The Shame Project itself has got links with a UK charity called Respond, which I don't know if you're familiar with, which works with perpetrators through this, what they call a Circles of Support and Accountability scheme, which creates a kind of community for those who have demonstrated sexually harmful behaviours and helps them to better understand relationships, including sexual relationships. And I think more broadly, that kind of empathetic model or empathetic approach towards perpetrators, for Respond, it's had a very kind of impressive success rate, if you want to think about it in that sense. And perhaps this kind of empathetic way of dealing with perpetrators would be a model more broadly beyond disability studies. So I'd be interested to hear your thoughts about that. But that is the end of my reflections, and I look forward to our discussion. Thank you.
Thanks so much, Steph. That was amazing. If the speakers could turn on their videos, that would be great. And I'm just going to change the view here to gallery. Look, there's so much we have to talk about, and we have 50 minutes. I've written a list here of things that came up in the discussions. I think I want to start with two, though. The first, I think, is perhaps Patsy Frawley could start us off, is about cultures of harm. And then I want to move to another theme that we look at throughout a lot of the papers, which is the lens of bodies, science and knowledge, including expert knowledge. But first, Patsy and maybe then Samina Molla, there's this wonderful phrase that Louise Hyde, who's a member of my department, who uses, which is cultures of harm in institutions of care. And I was wondering, Patsy, if you want to start off about how we can explain the fact that there are these really deeply embedded cultures of harm within institutions which really are purporting to be caring for more vulnerable people in the community, and then maybe move on to Samina.
Thanks, Joan. Look, I think it's a very it's a pertinent question, particularly reflecting where I am at the moment in New Zealand, where there's a royal inquiry into abuse in state care, and also in Australia, the Royal Commission into violence and abuse of people and neglect of people with disabilities. Both of these inquiries have really shone the light on what Paul Cambridge from the UK talks about, corruption of care, and where the idea of care is actually subverted into abuse, and that within that culture and that idea of care is also the sort of dehumanizing of people with disabilities as care recipients only, and therefore, moving forward perhaps onto the inherent victim. And these kinds of ways of talking about and then therefore institutionalizing ideas of care are really captured in the lived experiences of people who have given evidence to these royal inquiries in Australia and New Zealand, where their lives and for many people 50, 60, 70 years of their lives are lived experiences of daily abuse and under the guise of care. And look, I think without going into it any further, but to say that one of the things that's helping, I think, unpack some of this within these two contexts at the moment is that researchers in both places are using the frameworks of prevention and using the frameworks of sort of generic frameworks we have to talk about abuse that are around power and control, rather than really looking at and intersectionally too, looking at gender, disability, race, etc., as opposed to what we used to look at, which was the idea that the impaired person was the creator of the abuse, really. So that's just a couple of reflections, and I won't take up more time, but it's both historically interesting and currently interesting, and just about to do a bit of work in New Zealand with the inquiry into state care here, where we're looking at stories of people who were institutionalised, who are still around today, and who, with intellectual disability in particular, who want to speak about what that's meant in their lives, and then to the attempt we're attempting then to use that to sort of reflect on current systems as well. So thanks for the question, because it really does it really is timely in terms of the current work that's happening in both Australia and New Zealand at the moment.
Thanks. Sorry, can I interrupt, Samina? Well, we'll move to you in a minute. I forgot to say that, please, if anyone wants to hop in here, just wave at me or use the electronic hand thing to indicate that you want to you want to come in. Samina, sorry.
Thanks, Joanna. Excuse me. So it's a great question, and clearly, my first book is called The Violence of Care, and it's on forensic intervention into sexual assaults, and in it, I really document a lot of the ways in which that fusion of medicine and legal intervention takes control away from participants. But I really want to pick up your provocation about intersectionality. And I like to be very specific. I mean, there are clearly the term, right, we usually attribute to Kimberly Crenshaw in the 1990s, but we do see its roots and parallel notions in things like the Combahee River Collective in the 1970s. And Crenshaw is a critical race theorist who comes to us as a legal scholar, and she sets out the terms of intersectionality in two places. One in a treatise on labor law, right, and the harm that befalls people in the workplace. And then the second one is actually on Black women and women of color navigating criminal justice systems seeking support for gender-based violence. And a lot of times when we talk about intersectionality, we actually unmoor it from the specifics under which Crenshaw developed it. And so I really see it as a kind of clarion call to think about conditions of liberation, right, as opposed to layers of identity, which is, we're told not to take intersectionality on board as layers of identity. Intersectionality is about the kind of immutability of all of one's identities, and so we can't really unlayer them. And so the call is to think about what are the conditions under which people would be liberated, right? And so that is how I have approached the courts, right? Not just as a space in which there's potentially harm, but as a space where I wonder, how the science and the use of medicine and nursing is contributing or not to the possibility of liberation for people who are oppressed by gender-based violence. And so I hope, even though it's a strange snapshot that I selected for this particular conference, that it's very clear that the path is not the court way to liberation. And my problem is that, if we want to talk about victim-centered approaches, right, we have to make space for victims and survivors to really initiate the path to justice. And so all along the way, I think in everyone's work, we talked about it a little bit after this first session, there's simply no space for people to consent to participate in what justice might look like. And I think I really liked thinking about Evan's paper in that particular sense, because I think the other harm of particularly the criminal justice system is it individualizes gender-based violence as if it is not a social problem. It is as if it is not a sort of cultural set of conditions, right, that seeds people with power, like doctors, right, incredible access to be sexual predators themselves, right? So none of the papers, I think, are incompatible with one another. I think they all speak to a shared reality and one that has lots of different local variations. And I do think the way these mechanisms work out in the US, the way even in Milwaukee as compared to Baltimore, it can be really quite different. And many of the victim survivors that I see in court, there is an inability to recognize modes of victimhood and survivorship. So there were no adult men in the courts. They're sort of sorted out. The attrition does its job. And so there were children. I saw young boys sometimes. What is a rape victim and who they can and can't be, sort of seep their way into institutional processes. And, I follow in my ideas of the normal, maybe it's a little bit gauche to say, Canguilhem and Foucault really thinking about the normal as a kind of 19th century kind of invention of Western medicine, particularly in England and France, right, that really teaches us to see, in relationship to culture. And so I think it's really interesting to think about how all of the papers here have tracked what is normal and what is no longer recognizable as sexual harm. Or as sexual harm and healing and recovery from sexual harm. So people attribute, I think, healing and recovery to the courts, and that is absolutely true for some people, but it is not true for all people. And if we think about courts in the US and the types of harm they are visiting, not just in terms of sexual harm, but racial oppression on communities, right? We can really, I think, push back and question. So maybe my paper is a downer in terms of its call for a solution, but I'm deeply concerned that we are investing so much in the courts. And I think it was Kate earlier who was talking about in the previous session, like all of the resources, it might have been someone else, all of the resources that we put into, it was Ruth, all of the resources that we put into one kind of a solution. And these are, to the tune of millions and millions of dollars. But what courts do to prevent sexual violence, which is absolutely the end game for me, is actually very little. They do not really prevent a future of gender-based violence, except for potentially this one potential person. And so I really see the work that I'm doing as a kind of an abolitionist project. People ask oftentimes of me and my collaborators, like, how we're going to fix the courts. And I think Gethin gets really similar questions. How are you going to fix it? And, I really think that it is about narrowing its scope and potentially reallocating those resources, right? So I'll pause there.
Evan, do you want to come in here? Because this referenced your paper quite a lot. And then Suzanne.
Yeah, great. Thanks, John, and thank you, Samina, for that sort of nice kind of remark about my paper. And I think it sort of links to something that I was thinking a lot about watching all of the different videos, and I think what Joanna said about trauma having become a kind of master concept in this field. And I found myself kind of constantly asking the question, what are the political kind of limits of the concept of trauma? And I think precisely what Samina was saying as well about, I think I would also look towards a kind of an avenue of abolition, and whether trauma is kind of very inherently implicated in this idea of individual harm, and sort of also that transferring across to an individual legal subject as recognized by a court. And I mean, I think in my paper, I specifically chose this framework of vicarious trauma because it was one that enabled me to think on a sort of a community and a political community level. And I mean, in the papers I watched, I was especially thankful to Angelica, because her positioning of trauma as sort of being initially pushed by feminists or by a certain feminist understanding, as opposed to sort of my own kind of research up until now, where I'd basically sort of accepted this Vietnam veterans kind of organization from below narrative, really sort of brought that into political sort of focus for me, that it wasn't Vietnam vets kind of articulating it and then appropriated or sort of used politically by feminists, but actually maybe it could be thought another way around. But despite a lot of the ways that trauma, I don't know, let's say specifically psychodynamic sort of ideas about trauma, and I know a lot of kind of critical theories of race and anti-racist practices using terms such as community trauma to talk about racism. But I think I kind of, in myself, I remain a little bit skeptical, or a little bit sort of, I'm asking myself the question of if we need another language that is more able to address a collective political subject, as opposed to an individual sort of person being somebody who has experienced harm, to really address this question of cultures of violence and of a system that creates this, and of the people who are disempowered to act to address the harm that they experience. So sort of to move on beyond the courtroom, to abolish the courtroom, to look at how these violences take place. So I think it's a question for everyone really who address trauma is what are its political limits, and do we need a new language?
Thanks. Suzanne, your work deals with a lot of these issues. I mean, trauma is the center of it. Do you want to come in?
Yeah, I do, but do you mind if I just wanted to make a comment or a reflection on, I worked as a sexual assault worker in Australian services, and I was just thinking as people were talking, part of the role there and part of my role was to support people through court processes. But having said that, it was never a large part of my work, the same as the sane practitioners. So of course I did it, but so many survivors don't go through court processes. So I think we never saw court as about preventing sexual assault. So I think that what sexual assault service workers do really well is being able to hold multiple realities in place. So yes, part of your role is to help people prepare and go through and support them through the court process, but there is a whole nother level of intervention around preventative work that is much more community based. And the other thing, and this is just anecdotal, but of the many survivors that I worked with, the people who had gone through court processes, even where there was a guilty conviction, didn't necessarily seem to fare any better than the people I worked with who hadn't gone through court processes. So I just wanted to talk about that. So I think for me, it's around being able to hold multiple realities or multiple types of interventions. And I guess I'd never thought of the criminal system or court as being about preventative work, except on a very individual level. So thank you. That's what I wanted to say there.
Angelique, you had your hand up. I'm not sure if it's still up. And then I want to get Lisa into this because she also works on courts.
Yeah, I did have a comment, but let me cede my time to Lisa first, and I can jump in afterwards if if it's still relevant, because I like where the conversation is going, and I don't really want to interrupt the flow.
Yeah, I was just thinking when you were speaking, Evan, about the Royal Commission in Australia into institutional cases of institutional responses to child sexual assault. And it struck me that there was something incredibly powerful about hearing those individual stories. And when you read the responses of people to how they felt about giving those stories, I think for the first time ever, we had this kind of outpouring in Australia, a moment where it was okay to speak about being a survivor, and particularly for men actually to speak. So outside of kind of feminist circles, to the government and to say, that there's a problem here of trauma. So I think that there's nothing wrong with having a trauma idea that is somewhat individualistic, because I think it does have the promise and the reach to be more than that. When you hear one person's story, that's quite powerful. But when you hear 1,000 people speaking about it, that's a political movement. So I don't see that there's a disjunct between the individualism of trauma and, of course, individual harm is, based around an individual response and an individual legal subject. But I don't think that rules out a bigger political movement and a powerful political movement around sexual violence.
Thanks. Louise, your work, also Australian-based, where you also talk about the difficulties of doctors, other medical professionals speaking out about their trauma. Do you want to come in at this stage?
Yeah, I think one of the issues that was really important when I was looking through the survivors' narratives was that sense that that the professional identity formation was disrupted for these women. What medicine is, what their community is. There was a sense of dependency, because in medicine they are dependent on their seniors for progression. And so it had, a number of them drew parallels with abuse within families, that idea that who they were, their identity was disrupted. And there was one of my participants that came out with an extraordinary comment, which was after many years after the event and having had a successful court case. And I just wanted to agree with Lisa's comment about, the difference between those who went to court and those who didn't. But she said when she went back into medicine, she felt like she was hugging the walls because the floor was no longer safe. And it's I suppose, made me think about what that means in terms of professional identity. I think medicine is a little bit unusual in that there is a normalizing of bodies, there's a normalizing of sexual intimacy discussions in professional contexts that occurs in medicine in a way that it doesn't occur elsewhere, and that's manipulated into grooming by some of the perpetrators. And I think that that makes medicine unusual as a theatre. There's a reason why an operating room is called a theatre. There's something performative about that is unusual, and one has to wonder then what implications that has for both the perpetrators but also the victims in the way that they, or the survivors, the way that they then become doctors, who they are as doctors, and how they then relate to the community, and particularly the community who are vulnerable. So I think there's a number of parallels there with the way that gender is performed in medicine, the way that vulnerability is performed in medicine, the way that those women survivors then perform power, and their comments about the fact that senior women were the most abusive in the aftermath of their trauma, and senior women who, wrote letters of support for the perpetrators after the perpetrators pleaded guilty, and what does that mean in terms of who they become. So I think medicine is a very interesting field, and I think understanding how power and abuse is enacted within that field has implications for the broader community. So for me, that was where I suppose some of the interesting touch points were.
Yeah, thanks. Patsy put a really interesting comment in the chat, and if you could just talk us through that, Patsy, and then I want to go to Elizabeth, because also your work, Elizabeth, also deals with these sorts of issues. Then I plan to move on to questions of expert knowledge, because we have Gethin, Kate, Angelique, and Ruth, who may have who do have some interesting things to say there. But Patsy, can you just tell us what you were talking about in the chat, please?
Sure. So just in response to Lisa, what Lisa raised about the power of the Royal Commissions in terms of being places outside of courts where people's voices can be heard. A couple of things that I think is interesting is that the Royal Commission into Violence, Abuse of People with Disabilities in Australia followed those earlier ones, and in fact created a place and a space for people's voices to be heard, but also for the community to hear. It happens to people with disabilities too. Interestingly, in those other commissions and inquiries, there were many people with disabilities, and we've talked earlier about the connection between abuse and acquired disability. But to think about people with disability as a community of people standing up and saying alongside their peers in a place where they are going to be heard, and the consequences of that is that collective activism that can come from it, rather than the individual justice or not that might come from a court situation. And yeah, I think that I couldn't agree more, Samina, the funds, needing to be looked at in terms of going to advocacy, and Susan Egan from Australia too, recognising the important role that sexual assault workers do around their roles are called counsellor advocates for a reason, and it's about that recognition that there's advocacy both around the individual cases, but also a broader sense of advocacy. And some of the best work in Australia that's been done for people with intellectual disabilities has been done by Centres Against Sexual Assault in developing resources and supports to support people with disabilities in courts, and then to develop opportunities through victims of crime compensation as well. And this is really important work. And as a person who's worked alongside it, I always want to shine the light on that work, because without it, people with intellectual disabilities in particular would not be recognised at all as victims of sexual assault and have any form of justice, whether it's collective or individual.
Thanks. Elizabeth, do you want to come in here about the specificities of the military that you deal with?
Yeah, look, thanks, Joanna, and thanks to everyone for their comments and fascinating papers. I do feel like I'm a bit of an interloper here, working on, military history and sexual violence in the military. But I guess my perspective is that there is a kind of medico-legal governance or aspect to that story. There is a lot of work on obviously the Commission of Sexual Violence in wartime, but what we're hoping to do in the project that I was speaking about in my paper is kind of elicit, I guess, the parallel courts-martial process for the prosecution of some of those that sexual violence in wartime. And Samina's paper in particular has made me think very think of the need we have to think very carefully about the way that those kind of analog or parallel quasi-legal procedures operated. What was the role of the medical officer and the way that medical evidence was, adduced and then narrated? How are the legal protections for both the defendants and the survivor victims understood? And then, of course, there's that very fraught issue, which I touched a little bit on in my paper, about the way, in the transition from war to peace, how do civilian authorities deal with perpetrators of sexual violence in wartime? In the one case I talked about in the paper, there was extraordinary leniency granted to these men who had been dealt with very harshly by a courts-martial, by courts-martial proceedings. So that, I suppose, is partly the historical part of the work I'm doing. In terms of the present day, I don't know if we have a particular fascination of these kind of public hearings that do or don't lead to genuine change in Australia, but there is an ongoing conversation about sexual violence in the military, either perpetrated by members of the military, but also perpetrated within that institution, which has led to, I think, some very interesting conversations about victimhood within the military, not just about female recruits, which is obviously something, comparatively historically new in the institution, but also violence against male recruits as well. And I'm just thinking about some discussion in the chat about, where do male victims of sexual violence sit. And I do suspect in Australia in, the last, say, decade or so, with royal commissions, with talk about brutalisation within the military, and this sounds very cynical, but I wonder if the willingness of some male victims to come forward, unfortunately, has been what it's required to lend some credence to the issue in Australia. And that sounds incredibly cynical, and I feel almost bad voicing it, but there's a part of me that thinks, is the admission by male survivor victims of harm, does that give increased credence to a political class, which, as we know, to my Australian panelists, continues to be, white and male, and, middle and upper class? I might just leave it there before I keep venting. Thanks, Joanna. Thank you.
Shall we move? One of the other big themes that a lot of the papers look at is, of course, scientific knowledge, the role of the expert. Gethin, do you want to start off this part of the discussion about the role of the expert in establishing norms, in affecting influencing court cases, and the ways we think about it? And I know there are a number of other people who will want to, I hope, come in here in terms of psychiatric knowledge. But Gethin, do you want to start us off?
Yeah, well, I've been obviously very fortunate. I was able to attend both sessions, and I went to bed last night absolutely buzzing with all of the wonderful conversations that were taking place, and it really led me to think. So Stephanie asked the really important question: what work is medicine doing in this context? And at one level, we could be cynical and we could say, well, it's not doing very much. Maybe it's changed the nature of defenses so that you get, the rise of DNA technology is, made it much harder to have a stranger defense anymore. So, it becomes a consent defense. But you could also see that in a sort of more positive light. The work of Janice Demont and Deborah White, the wonderful paper in Social Science and Medicine, has drawn attention to the way that the survivor victims were felt far more relieved about the presence of injury evidence and the discovery of injury evidence, not because it was going to go to a judicial narrative, but because they could tell their mothers, their fathers, their friends there was something to support the collective community, that there was evidence of the harm that they could present external to their own testimony. Now, that's troubling on all kinds of levels about how we trust. But that was actually something that people said, that the survivor victims said that they had benefited from the forensic intervention. But one of the things that I wanted I was really thinking about last night was this question about evidence. And there was a lot of conversation that played through yesterday about what is evidence. And those of us from the sort of sociology of scientific knowledge side of STS are very keen to promote this forgotten the word for it now, but the underdetermined nature of evidence, that the evidence does not speak for itself, that it needs to be framed, and it's always contingent and open to question. And another of the things that we talked about yesterday is that very few of the papers talked about consent. And I think that actually one of the things that's happened with forensic medicine is that consent has so much work has been done by forensic medicine to make consent not part of its job description. We will not talk about consent. We will talk about force potentially, if there's some evidence for that. But this is the legal questions and these are the medical questions. So they've drawn quite a stark boundary between these two. But at the same time, they do a lot of work to discover a medical response to consent. So if you follow forensic medical journals, every year you will find 2 or 3 articles which are case summaries of thousands of genital injuries, anogenital injuries, because they're trying to find the determinant rape injury, quote unquote. And so there's a lot of work being done around this boundary about what is consent and what is the evidence that marks consent and where can it fit in order, because as soon as they determine that there is this particular injury, although it would be open to question on all kinds of bases, but if they were, then consent would be in the medical purview again. So that is particularly interesting. So back to the underdetermination. So if we think about this in terms of the framing in which evidence is done, even though there is the talk that the evidence speaks for themselves, what Samina's work has showed really powerfully is that, you also have, like Adams's, it's normal to be normal. And so the framing of the lack of injury does not, in fact, speak for itself. And actually, forensic professionals are very keen to intervene at that moment to say, actually, it is normal to be normal, and that the lack of evidence is not evidence of a lack of forced intercourse. The problem that we have, and that Samina and colleagues have all drawn attention to, is the current framing, both in the medical and the legal world, the difference between the evidence and the framing and meaning of that evidence is framed around racial, classed, gendered discourses that do not support survivors. And so I definitely do not have the positive spin that we've been pushed to have, but I think that's where some work could be done. What does that new framing that isn't, and how does transformative work, that's why I brought up the Janice Dumont and Deborah White's work, because the framing of forensic work could be done within a context which is supportive and not cynical, but providing support potentially. But how can we reposition these debates so that the evidence, I mean, who am I kidding? At the end, if we do remove the cynical individualist framing of criminal justice, then forensics is out the window, right? We don't need forensic medicine anymore because we're undermining that. So I'm not sure, this is just, like I say, the buzzing about in my brain that went around after yesterday, but I think there's something to remember to try and capture about the underdetermination of evidence, and that evidence doesn't sit and speak for itself. It speaks within a whole milieu of claims. So I hope that at least starts a conversation, if not ends one.
Kate.
Thanks very much. I'm keen to sort of jump in here before it sort of switches back in the other direction, because I like Angelica, I liked the way that the conversation was going, but I'm going to sort of have a little blip here, I hope. But on the question of evidence, I think probably one thing that I didn't really kind of make very clear in my presentation was the idea that the psychiatrists that I've been looking at, and as I said in my introduction, my work is really about the history of the treatment of so-called sexual disorders. So things that were included in the Diagnostic and Statistical Manual during the period of the 1950s and 60s as sexual paraphilias or disorders or disordered sexualities or something that was abnormal. And one of the things that these psychiatrists in the 1950s and 1960s, particularly the 1950s in Czechoslovakia, were trying to do was to figure out what sexual orientation is, and what that actually means. So is pedophilia a sexual orientation, for example? Is a hebephilia a sexual orientation? Is being a rapist a sexual orientation, or is it a crime? Or is it a form of interpersonal violence and harm? And this was kind of, these are difficult questions to sort of be addressing, but it does go to present day, debates and arguments that go on about funding and controversies around, treatment programs for people who think they might be a pedophile and that they might harm children, and whether or not they can get access to preventative programs that are actually going to, Joanna, in your remarks, you talking about the other side of things. So a lot of our conversation has been around what happens at the courtroom stage and evidence that is provided after the harm has been committed or perpetrated. But the psychiatrists that I've been looking at, we're really kind of looking at the period before. Is it possible to actually stop the harm from occurring in the first place? And can we do that by diagnosing a harmful sexual orientation rather than necessarily having to prove whether or not sexual harm takes place? So this is kind of like it's a very, very different level of conversation to be having. And it does kind of also go to this idea of, perpetrators as victims. Is the reason why people, later on perpetrate sexual violence, is it that they were victims of sexual violence themselves? Is that something that has caused an arrest in their sexual development, for example? That would kind of link into the idea of, pedophilia being a sexual orientation, for example, or rape, the drive to rape women being a sexual orientation. Has that been a result of some kind of earlier harm? And has that shaped sexual desire? Or does it have nothing to do with desire at all? And so these are the kinds of questions that these psychiatrists were trying to sort of grapple with in a clinical sense. And that's why they were so keen to try and develop empirical instruments that could diagnose desire, not necessarily prove whether or not someone has been harmed. It was really about developing empirical instruments to diagnose what makes this person aroused, and can we correct that, or does it need correcting? So that's, and I think that that's a kind of an important thing about where consent comes in later on. Is this form of arousal something that is going to cause concern in questions of consent, or is it something that we don't really need to worry about? So this is kind of where my paper dealing with the normative, non-normative aspects is really kind of at that level of the conversation. So I just wanted to sort of throw that in as well, because a lot of the homosexual men that were part of the study that was done in Prague in the 1950s, a lot of them did have desires for, people who would be regarded as minors, but they had come in, first of all, through the lens of having homosexual desires. And then the psychiatrists involved in the project thought, well, we need to kind of control this. We need to figure out whether or not this is a phenomenon peculiar to people who have same-sex attraction, or whether it's a phenomenon that is broadly and generally kind of spread across the especially male population. And one of the reasons why the empirical instruments that they were developing were so crucial to their research is because it enabled them to figure out, actually, this is not a phenomenon that is peculiar to same-sex attraction. So the problem really lies somewhere else. So yeah, I think that's all I wanted to say for now.
Great, thanks. I mean, but Ruth, this does bleed into your paper, where you also look in the context of children about questions about earlier harms shaping future acts or future or fears that it will at the community medical level. So I'm just wondering if you had something to add to this with regards children and perpetrators as victims.
Yes, I mean, I suppose one of the points that I was trying to make in my paper is that the origins of some of these ideas are so not evidence-based that it's laughable, you know. So some of the ideas that came from the UK to the UK from America were based on tiny cohorts and people's atrociously gender-bound, class-bound, racist kind of beliefs about families and about children. But they were picked up and became expert knowledge here. Another point that I was trying to make, which perhaps was a bit different from Kate's, or I hadn't thought about it until I watched Kate's video, was, you know, I think, Kate, you were talking about the victim being absent from these sorts of this thinking about perpetrators until second wave feminism. But from my reading, the victim remained kind of absent. It was almost like for children, there are two silos of development in this thinking about child sexual abuse. There's a kind of a clinical psychologist silo where people became very expert based on the behavior of adult sex offenders and tracked back to children. And then there was a separate sort of learning or knowledge base happening in pediatrics and child psychiatry, and that never the twain shall meet, really, you know. And I would like to say that I think that there is still a massive siloed effect between these different branches of people clustered around the child, which has very detrimental effects to any kind of holistic approach to prevention. And really interested in what Samina said about the specificity of certain concepts and, you know, talking about intersectionality or trauma. Both of these things are taken from some quite intricate theorizing, and they're brought into the mainstream as a blunt instrument and used to personalize ideas and to individualize what is happening to people and to take the eye off the structural you know, allocation of resources. We all agree that advocacy is amazing. In the UK, it exists on a shoestring in terms of financial support. It exists on a commissioning basis from year to year or a 3-year cycle. You know, children have to travel long distances to be taken to see a sexual abuse nurse in a centre here in the UK. If a child does disclose anything, people are told it has to go to experts. So a child is then taken to a stranger to be interviewed by a police officer and a social worker. This is not how children's minds and conversations work. So there are huge implications. And I think that the last thing I wanted to say was, Louise, I was so interested in your paper about doctors abusing doctors, because a lot of my oral histories are about, you know, I ask people generally about child protection and when they came across that in their training, and then I gradually move into talking about child sexual abuse. And of course, the gender base in pediatrics and psychiatry has changed enormously since the 1960s and since child protection started to form. And I'm really interested in how the women who were trying to juggle, you know, their own families, their professional status, work with their senior male colleagues, you know, if they, you know, they can't even speak out about being sexually harassed and abused themselves, how the hell would they speak up for any child that they meet on a ward or in the community? So that was really interesting to me. And I think it's interesting to me how much I will be able to track changes in attitudes to child sexual abuse as we see the gender balance in at least parts of medicine and psychiatry changing. So yeah, lots of scattered thoughts, but yeah, that's what happens when you've got so many brilliant minds in the room.
Excellent. Yeah, we have about 7 minutes left, and I want to get Angelica back here because I realized that we kind of moved away from, she had her hand up and then we moved away and we haven't actually brought her back in. And then just as a final, after Angelica's reflected on what we've heard here or what she wants to say, maybe if we could each of us sort of just very briefly say, well, what would we like to see? What research would we like to see in the future? What is the future? And we'll start with Gabrielle for that. But Angelica, I'm so sorry. We kind of missed you out there. I kind of.
Oh, no, please don't be sorry. I have been learning so much and the conversation's been going in directions, and I didn't want to sort of detour it in a different direction. There's so much I want to speak to, but I a couple of times I think we've talked, you know, about the limitations of the court system and the focus that maybe we want to put on prevention. And one thing that I sort of want to, I guess, throw out there, and particularly because I was hoping we would get to talk a little bit more about embodiment and bodily harm and how that's involved in these conversations. But one thing I just kind of want to throw out there is the way that trauma could be thought about as sort of a public health problem, and sexual violence in particular. And by no means is that a new concept, but one sort of more recent development in that history is like the Adverse Childhood Experiences Study, which was conducted in the United States in the late 1990s. And what is the focus of the study is the prevention of trauma. And their claim is that if we were to label something as a public health problem, and then there would be more resources that would be going towards the prevention of something rather than the treatment of its effects on the people who have experienced that. And, you know, part of me is enticed by this idea of sort of labeling sexual violence as a public health problem, because it can lead not just to psychological conditions, but also it can lead to people to turn to particular coping mechanisms that can then lead to later life health problems, which is a big, you know, part of the Adverse Childhood Experiences Study, is that trauma really does contribute to diabetes and heart disease and all of these bigger, really serious issues in the United States, but everywhere really. But on the other hand, and as sort of people have just been talking about with children, I am always kind of wary of labeling experiences of children in a medicalized fashion all the time, particularly when it can invite in institutions like social services into the family home to sort of monitor and surveil families. And that is like one thing that I think labeling something like sexual violence or adverse childhood experiences, more broadly speaking, but sexual violence in particular in the family home can have sort of a negative effect, and particularly because not all families, not all communities are going to be surveilled and controlled by systems like the social services system or others like that in the same way or to the same degree. Of course, you know, Black and Brown communities are going to be much more, are going to have those systems invited into their homes and into their families much more than others. Anyway, so I sort of want to loop that in here and part of the conversation, because it does sort of attend to how sexual violence is embodied, and it can lead to bodily harm, not just psychological harm, and that's really important. And it attends to the way that, yes, it impacts individuals, but this is a much larger issue. It's like a public health issue, but as sort of everybody has been, I think, saying, there are really complicated interplays between labeling something as something for the criminal justice system or something for the medical system to solve. And it invites sort of, different degrees of surveillance to different communities. And I just want to point to this really wonderful, I think, conversation that's been in the chat as well, and sort of the ways that trauma talks about development, and sort of the ways that development is thought about in different ways for different types of individuals, racialized individuals, disabled individuals. And one community that we haven't really talked about is like elderly people, and sort of difficulties that can pose, particularly people with dementia. Like Anne Burgess, who researched rape trauma syndrome, has done work on that as well. And that's very difficult to sort of prevent and even find, because people with dementia, of course, have some issues with their memory. Anyway, so I'm going on now. I have too many thoughts, but I'll end there.
Lovely. Thank you so much. Really, really great. Look, we've got just 4 minutes left for some quick reflections. I mean, I don't know, Gabrielle, do you want to start us off, and then anyone can sort of come in?
I was just thinking, I'm sorry to talk about myself again, but I'm like a victim of incest, and I told the police a couple of years ago about it, and they said there wasn't enough evidence. And I was just wondering, what do you do in those situations, like where you know, you're not seen as where there's no evidence, where evidence is really important. And also I really hate the way victims of sexual violence are re-victimized in the psychiatric system, like as well, like how they're pathologized when what they're going through could just be trauma, not schizophrenia, for example. Yeah.
Thanks very much. And certainly, just for those of you listening, Gabrielle has a wonderful book of poetry that I really do recommend to everyone. Thank you. Does anyone want to come in here? We have just a few minutes left. Yes, Samina.
I just want to acknowledge that that it is a really big deal and really generous when someone shares with you their own experiences. And so I want to thank Gabrielle for speaking from her own experience. And then I want to, maybe this is a little bit dicey, but what makes me really angry is when the legal system gets internalized by us. And so there's not enough evidence when your story should be enough. So I believe you. And I think everybody here believes you. And I think that's what a lot of us are kind of pushing against. So I've been doing this for 20 years. I get emotional and angry every time I hear a story like that. And just in terms of what I think we need to do, I think a lot of us are moving into continuing to push back against these larger systems, taking very seriously what transformative justice looks like. It's very sobering when people say, no, but justice to me is in the courtrooms, right? And it's very hard to hear. I know we had this conversation earlier, people saying, abolish the courts, right? And I really want to know, what will accountability look like? It's not about abolishing accountability, but it's like, what can accountability look like? And so that's where I'm kind of moving. And so one of the things I'll be doing is, having sat through like 90 sentencing hearings, kind of looking at how we diagnose sex offenders specifically within courtroom spaces, right? To kind of think about what is institutionalized accountability right now. And I'm going to be contrasting that with some of the transformative justice movements that are working in the US, at least things like Insight that Evan cited earlier. So just thank you, everybody. Really inspiring work.
Thanks. We've actually run out of time. And I think that, Samina, that was just a really fantastic, I can't think of a better way to conclude this session. So thank you. Before, I've just got two announcements to make. Firstly, we have another public event coming up on the 26th of May. It's a Wednesday. Check our website. It is the public event, the final public event for our writer in residence, Winnie, who is just an amazing novelist. Some of you may know her novel, Dark Chapter. She'll be speaking to a group of other people, including the prize-winning author Claire Shaw, on creative responses to writing, researching, and surviving sexual trauma. So please check our website for that. And also, just to say that in November, end of November, we have Shameless Festival. It's a shameless festival of activism against sexual violence. It's on the 26th and 27th of November, and we are doing this with the WOW Foundation, a global movement celebrating the lives of girls and women. So please keep an eye on our website for that as well. But just to conclude, thanks very much to everyone, to Ria, Sukdiosing, who is our public engagement and events coordinator, who is the person behind everything that happens in the Shame Project. So thank you so much, Ria. And also, of course, for all the speakers here today. The two sessions will eventually be up on our website. So if you missed the first one, because it was 4 a.m. for you, please, in a few weeks, you'll be able to watch it on our website. Thanks to all the speakers, and many, many thanks also for all the participants in this event. Thanks very much. Bye.
Thank you so much.
Thanks a lot.